Hi, this is other stuff I really couldn't fit anywhere else. Here he goes. George McMurphy is 45. He's from northern Minnesota. This is important because the disease he has, multiple sclerosis, only seems to happen in cold climates. It does occur in places that are warm climates, but nowhere near the percentage of people develop MS in Texas that develop in the northern climes, such as Minnesota or Maine or New Hampshire. George's got a couple of kids. He had had some chest congestion. Actually was losing his urine, which obviously is a very concerning sign. He's got low energy. He's weak. He's fatigued. He's got a little bit of spasticity in his legs. Now, some of these symptoms, as you can see, a little bit of chest congestion, a little bit of weakness, a little bit of fatigue, all of those are very nonspecific. That makes MS a very difficult disease to diagnose. He has now developed pneumonia, and it's really increased his symptoms. So MS is an autoimmune condition. It occurs in demyelination. And so usually that's the white fibers in the central nervous system. And what that means is normally you have a nerve. Lots of times those nerves develop a myelin sheath, which is this little thing that is on the outside. What happens is that myelin sheath can deteriorate. That one looks fine, but this one is deteriorated. That one's deteriorated. So instead of the nerve impulse bouncing along like this, choom, 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 it bounces and then it slogs and then it slogs. And that's why people will have impairment in a lot of neurologic functions. One of the classic presentations of MS, although it doesn't happen all that often, is double vision. So you think about it. You got one eye that's everything's working right with the muscles. The other side is slowed down, and therefore you're not going to have your eyes seeing the same things all the time. You're going to have double. So you'll have double because the eye muscles aren't coordinated. Your weak and strong muscles may contract in an unorganized fashion. You get a little bit of spasticity. Your bladder may start having problems. That's usually a late sign of MS, though. And so these folks get a lot of pneumonia. They get some UTIs. Some people only have a single episode of MS. But for most people, it's either a progressive disease or it's a relapsing remitting disease. So you'll have people that will go years without a problem, and then they'll have a relapse. The people that have a progressive disease just get worse and worse and worse, and then eventually die. The relapsing remitting people will have ups and downs. It is very unpredictable. Very frequently, people with MS will have an intention tremor. We talked about in the Parkinson's disease that those people have a non-intention tremor. Ataxia is a disorder in balance and coordination. So if you interfere with that autoimmune breakdown of myelin, you can actually decrease the symptoms. We'll often use interferon, which will break down that breakdown. And so Avonex, Betaseron, and Copaxone are medicines that have been used for many years. All of them are injectable. They're very expensive. We now use monoclonal antibodies, and so Tysabri is the one we use the most with MS. And there is a condition called PML, which is a leukoencephalopathy, which basically is a brain disease, is associated with a previous infection with something called the John Cunningham or JC virus. And so people that are going on treatments for MS really do need to be tested for the JC virus. Gilenya is another medicine that will actually interfere with that autoimmune process. It's not a mab. Steroids we'll often do, lots of times we'll do Solu-Cortef, 125 milligrams, every 6 hours if someone has pneumonia. And someone with MS will often do 1,000 milligrams. And some of those patients that are having a flare-up, it'll knock them down, make them feel a lot better. People with MS may do great. But if the disease is progressive, they'll usually get a severe UTI or a pneumonia. Arthur Joste. Arthur's 73, lives with his wife. They've got 4 children, and he's a retired history teacher. For the past 9 months, he's had a hard time remembering friends and phone numbers. For the past 18 months, he was forgetting the news, he was miscalculating his checkbook, he was starting to neglect his hygiene needs, and he started to get problems with his kids and his grandkids' names. Now, a lot of people have memory problems as they age. We call that minimal memory impairment of aging. But when it crosses a line, we start worrying that they've actually got some deterioration of their brain. And in this case, we do think he probably has Alzheimer's disease. It is not the only thing that can cause confusion. Parkinson's disease can also get a dementia. Multi-infarct dementia is actually where you get a bunch of small strokes and you'll actually have cognitive issues. These strokes don't seem to affect the motor areas, so you don't notice them as much. Hypothyroidism can actually cause a little bit of confusion. Chronic anemias also make people have a hard time concentrating and feeling well. Now, we may have a temporary confusion as well if he's got an electrolyte change or an infection. Unfortunately for Arthur, he's had this for 16 or 18 months, so it's less likely to be a delirium. The delirium is usually something that happens postoperatively or with an acute infection, and it usually will only last a matter of days or, in extreme cases, weeks. So after an extensive workup, he was diagnosed with dementia of the Alzheimer's type. Senile is a term we don't use much anymore. And he may have a genetic component. There are people that do have that, but it does increase with age. If you look at people that are 85 or 90, roughly 80% of them have some dementia. So it's not just age, but it's not just genetics either. It seems to be a combination of 2 things. So people with Alzheimer's disease will get plaques and tangles, the brain will atrophy, and the neurotransmitters decrease, especially acetylcholine. So if we give a medicine that is cholinergic, that promotes choline issues, you may actually be able to improve the cognition. So examples of that would be Aricept and the other medicines that we use for dementia. When someone has a head injury or if they have dementia, the lobes are going to have a major difference of what's perceived. Frontal lobe, they're often going to have emotional issues. Parietal lobe, they'll have perception issues. And temporal lobe, they'll have difficulty with laying down new memories. So many people with Alzheimer's disease have a lot of their plaques and tangles in that temporal lobe. May get to the point where the patient's not able to maintain touch with reality. They may actually have hallucinations and delusions. And so if we give something that increases the amount of acetylcholine, we could affect it. We can also do that by breaking down the enzymes that would normally break down acetylcholine. So it basically stops those enzymes from breaking it down. So it increases the acetylcholine levels in the brain. These meds are the Alzheimer's disease meds, Aricept, Exelon. Now the problem, of course, is that if you give cholinergic, you can actually end up with other effects, nausea, bladder changes, heart problems. So just remembering what the acetylcholine does in the body. We could also block NMDA receptors. Now these moderate or modulate the effect of glutamate. And by blocking those receptors, we actually can increase cognition. So Namenda, NMDA, Namenda, or memantine, does have an effect. We usually only use this from moderate to severe dementia. We don't use it with mild dementia, but it can make a big difference for people. So in this case, the pharmacology doesn't make a huge difference. Most of these people will have progressive dementia, but we may be able to slow it slightly. And for most of these people, most of their care is really based on functional and behavioral approaches. And drugs for the week: the Tisabri, the Gilenya, the Avonex, the Betaseron, the Copaxone, Aricept, and Namenda. So enjoy.